A very good morning to all of you, and I welcome you all to 43rd Asian Pacific Dental Conference. I am Professor Dr. Ifat Batul, Head of Orthodontics Department and Dean of Dentistry at Akhtar Said Medical and Dental College. Today we shall be talking about management of cleft lip and palate patients, which is an arduous journey to acme. Some people see things and say why. I dream things and say why not. A thing of beauty is a joy forever, well said by Charles Keith. And the people who do not have that beauty, if you bring out that out of them, you cannot feel the joy more than that. And if you don't believe it, treat a cleft patient and you will really feel the joy and satisfaction within you. Man-made wonders have some very beautiful symmetry in them, be it an Eiffel Tower, Taj Mahal, or pyramids of Giza. What do all of them have common? That is the symmetry. And what do you think? That symmetry is also portrayed in human being, in human smile, that is an arc in a line. And if that arc has some flaws in it, if it is not flawless, do you think those people are little lesser than us or not better human than us? No, it's not a truth. The actual fact is that God has created every human being with a balance, with a proportion. And He Himself has said to do research. And for that research, we try to mimic that golden proportion in human beings and to make them more beautiful, to make their smile worthwhile. Constantly battling a stigma that grew consequently to the lack of awareness and lack of education in our society for treating cleft lip and palate patient, I personally vowed philanthropically and I pursued to take up the cleft lip and palate repair. This is the cause which I hold so close to my heart. When I hear a phrase, a smile goes a while, my heart goes with those hundreds and thousands of children who do not have that beautiful smile. Because this cleft lip and palate treatment is a multifaceted treatment which requires a physician, parent and the patient together from birth till 20 years of age. This is a 3P quintessential intervention treatment in addition to timely sequencing that with the cause one can be achieved with profound social education on the matter and with lot of tedious work and help of the physician, dentist, orthodontist, maxillofacial surgeon, pediatrician and the plastic surgeon as well. As we see that human beauty and perfection is evolving day by day, and the fuller lips and thick lips are considered the sign of beauty. Therefore, we try to mimic it in every human being, be it a cleft lip or cleft palate or any other with malocclusion. And this can be seen that Joaquin Phoenix, he played the role of a king of Rome in the movie Gladiator, which is an Oscar-winning movie, and you can see the confidence he has shown in that, in spite of having a cleft lip repaired. The actual confidence lies in the surgeon who treated it with minimal scar tissue, and that is our aim even for today. Cleft lip and palate has been considered as social stigma and since ancient times. In many civilizations it has been considered as devil's curse. And even today at the era of scientific logic, its etiology revolves around many myths. Therefore, we need to know that we want to educate the people that this has nothing to do with the devil's curse and it is totally treatable, but the child and the patient has to visit the orthodontist from birth till 20 years of age at least. Cleft lip and palate is 1 in or 1.82 in 1000 births, and this is a crack in a normal wall, a crack in a normal structure. There is a missing tissue in that area. So we need to build up that wall. We need to make that wall seem flawless. So to treat that, it requires a multidisciplinary approach, and that approach is of different specialities, but among them the orthodontist plays the role of chief coordinator, because the orthodontist is the one who has to do the sequencing and treatment timings of different treatments every time, and it starts from birth, exit from primary school, and then entry into high school and exit of high school. These are the important timings in one's life where the orthodontist, surgeons, maxillofacial surgeon, ENT specialist, speech therapist has to play different roles according to their speciality. The schedule of the treatment of cleft lip and palate patient here lies with the orthodontist, where orthodontists keep on intervening, planning, sequencing the treatment of the child and keep on referring the child to different stages to different specialists. Among all those treatments and all those stages, the NAM, nasoalveolar molding, is the most important event which starts immediately after birth, for which the child need to be taken care with the orthodontist. Newborn cartilage is soft and lacks elasticity. The higher level of estrogen correlates with the higher level of hyaluronic acid, and it lacks the linking of connective tissue. Therefore, the softness of connective tissue, cartilage and ligaments make it easier for the fetus to pass through the birth canal, and exactly same is the reason of the higher level of estrogen and hyaluronic acid that makes the baby alveolar bone more moldable and reshapeable. This level starts decreasing immediately after birth, and they are at peak at the first 72 hours, and after their decline of the estrogen, consequently decline in the hyaluronic acid makes it a little difficult to correct the alveolar bone. And first 6 months are very important in this, that the free circulating proteoglycan concentration is highest, and at that time it is easier to mold the alveolar bone. At the same time, the baby is small, he lacks the dexterity to dislodge the stent or the molding plate, the skin sweats less, it is easier to apply the tegaderm on the skin, and you get the maximum cooperation from the mother and the baby as well. Therefore, the NAM is one of the most important treatment at the beginning of cleft lip and palate patient, and that should be taken immediately after birth. Now I will be showing few of my cases, that is the bilateral cleft lip and palate and unilateral cleft lip and palate, which has been treated immediately after birth with nasoalveolar molding. This is a patient with alveolar cleft who has, you can see appreciate the premaxilla is too forward than the even nasal tip. So for that impression was taken in the alginate, and that nasoalveolar plate was formed. But this is a paradigm shift from alveolar molding to nasoalveolar molding, where the later on surgery of the columella of the nose and nasal tip can be avoided. Here the nasal tip and the columellar lengthening can be achieved along with alveolar molding at the same time. So nasal stents are attached to the alveolar plate, where it curves around the plate like a swan neck, and it passes the nostril aperture 3 to 4 millimeter beyond the nasal aperture, lifting the nasal columella and nasal tip. So, this is a pre-surgical approximation. Tegaderm has been applied on the skin of the baby so that it should not cause any irritation, and then a plate is given and you can appreciate the pre-surgical and post-surgical nasoalveolar plate of the alveolar premaxilla of the patient. And now if we see at the cast, you can appreciate the lesser alveolar segment and the greater alveolar segment from the premaxilla reduces the distance, because premaxilla has been pushed back and the lateral segments are opened up to accommodate the premaxilla into that space where the two segments are missing, or there are two clefts on the right and left side. These clefts are usually at the lateral and canine regions. Therefore, you can appreciate that the distance between the greater wing of the alveolus and the premaxilla has reduced from 6 millimeter to 3 millimeter, and here the premaxilla has been pushed behind, and both the segments show that the palate has achieved almost a normal U shape. Post-surgical, 2 weeks after the nasoalveolar molding, the patient has been referred to the plastic surgeon or maxillofacial surgeon, where they can treat the lip with a very lesser scar. And you can see that after the surgery, we have to give nasal conformers to maintain the shape of nasal columella and nasal aperture, so that this correction may not relapse immediately after surgery. Now, this is a complete journey from the beginning to the end, where nasoalveolar molding has been achieved till surgery and post-surgical treatment and the confidence of the baby and the mother. There is a case of unilateral cleft lip and palate. Here, the baby reported at the age of 10 days, and here the objective of nasoalveolar therapy is to correct the alveolar defect and to correct the nasal aperture as well. And then the patient will be referred to the maxillofacial surgeon or plastic surgeon or pediatric surgeon, where they can correct the cleft lip. And now if we see, we have taken the impression for the baby, given the tape, alveolar plate for labial approximation and the nasal tip correction. Once it has been achieved within 3 to 4 months, then the patient will be referred. For bilateral cleft lip and palate, usually this time is a little more, because it also depends on the size of the cleft for approximation. But the target with the orthodontist is from 3 to 4 months, so that it can be referred to the surgeon as soon as possible, and of course after achieving and attaining the rule of 10. This is a patient post-surgically. You can appreciate the nasal tip and the nasal apertures, and this is a complete journey from the beginning, then the impression taking, to the nasal taping plate. Pre-surgically, the lip has been approximated, and post-surgically the nasal conformers were given to conform the shape of the nose and nasal tip and nasal aperture. After the nasoalveolar molding comes the toddler years, and they are very important in a child's life, because at that time one has to develop a very good speech. Usually the children born with cleft lip and palate, they develop a very good speech by the age of 5 years, but because the nasal cavity and oral cavity are not separated in the beginning, they have a difficulty in speech development, and this speech development could have an hypernasality, or there will be difficulty in producing the consonants. Therefore, the palatal repair is vitally important before the age of 2 years, so that the speech could be developed easily. If the palate and lip is repaired at the 2 years of age, it could lead to another complication, that is the retrusion of the maxilla. However, the retrusion of the maxilla can be treated later on, because still the growth of the maxilla is still left, but speech could develop only from the 2 years to 5 years of age. Therefore, velopharyngeal competency, palatal repair should be done at the age of 2 years. It is very common for the children who have cleft lip and palate to have swallowing difficulty, suckling difficulty, distortion of speech, difficulty in production of consonants except the nasal ones, and other than that they could be an articulating problem. For these children, we need to repair the cleft, but if there is any defect, any velopharyngeal insufficiency is still there, then that needs a prosthesis. That is palatopharyngeal prosthesis. The soft palate, lateral and posterior pharyngeal wall, they form a sphincter, and that sphincter is called velopharyngeal valve or velopharyngeal sphincter, and that velopharyngeal sphincter closes the nasal cavity and the oral cavity and the pharynx during speech, suckling, swallowing and production of the different oral functions. But if it does not close naturally, then palatopharyngeal prosthesis is the one that is called a bulb, which can be fitted. It has different retention mechanisms. It can be given for the child above the age of 5 years if it is not corrected at that time and it is beyond the repair. Now, at cleft lip and palate patient, the orthodontist has the chief coordinator of the team. He is the architect of the main treatment planning. Therefore, the sequencing of the treatment and the timing of the treatment are dictated by the orthodontist. And orthodontist needs to be involved at different stages at different age of the patient. From the very beginning, nasoalveolar molding immediately after the birth is one of the very prime importance. And then at primary years, intervention for preventive orthodontics and referral to different speech therapists. At the beginning of the teenagers, they need orthodontic treatment, and after teenagers, they might be needing orthognathic surgery, which is again in collaboration with the orthodontist. Now, for all this, the orthodontist need to correct the orthodontic treatment, the psychological well-being of the patient, and alveolar bone grafting is also required. Now, it is the sequencing of the treatment. Again, I would like to emphasize on this that the orthodontist has to refer the patient for alveolar bone grafting. Now, what are the alveolar bone grafting stages? Alveolar bone grafting could be primary alveolar bone grafting, secondary alveolar bone grafting, and tertiary alveolar bone grafting. Now, the optimal timings, and also these patients of cleft lip and palate usually end up in class 3 malocclusion, and that class 3 malocclusion is a little difficult dilemma for the orthodontist because the craniofacial structure growth is unpredictable in these patients. Therefore, one is also not sure about the missing structure of the premaxilla, vomer bone, alveolar cleft, and the dentition as well. So, CVM stage 1 at the age of 6 to 8 years is usually very important age in this patient, in which one can take up the palatal expansion. Palatal expansion is a transverse correction of the maxilla, which could be done at CVM 1 stage at the age of 6 to 8 years with a slow expansion, where the transverse correction can be achieved non-surgically in cleft lip and palate patients. Then comes the dentofacial orthopedics. Dental or facial orthopedics precedes the palatal expansion, along with that or immediately post that, and that is the face mask attached to the elastics with the extraoral force is applied to the face mask, which will lead to reshaping, redirecting the maxilla, and which may restrict the mandible or the condylar cartilage to some extent or redirect the growth of the mandible. However, whatever the case may be, the segments of the craniofacial complex at this stage, there will be an anterior positioning of the premaxilla, frontal bone, and also the anterior alveolar region of the maxilla as well. Primary bone graft is performed at early childhood at the age of 1.5 to 2 years of age, and same times the primary repairs could be done. But the secondary bone grafting is done at the age of 7 to 8 or 7 to 10. Here, the grafted cancellous bone fills in the residual alveolar cleft and is anatomically joined to the adjacent bones, becoming indistinguishable in radiographic images after an average period of 3 months. Secondary alveolar bone grafting is done when before the eruption of the canines, when their roots are 1/2 to 2/3 formed. And tertiary bone grafting is done later on in adults where there is still a residual defect. Here, the problem could be the root resorption, which is caused by the contact of the grafted bone to the exposed root surface, and progressive root resorption on the cervical thirds of the roots is common side effect in such cases. Post-bone graft orthodontics starts 3 months after the bone grafting procedure. Once on the radiograph, we are sure about it that the grafted bone and the adjacent normal bone are just joined together radiographically and there is no residual defect left. And here now the movement of teeth through the grafted area could be carried out. After the bone grafting, there comes the pre-adolescent stage of the child where the major important treatment needs to be taken care of. The early treatment of class 3 malocclusion has been a real challenge to the orthodontist because of its multifactorial nature and the growth pattern of the craniofacial structure, which is unpredictable. It contributes to the dilemma. The vast majority of the cleft patients at this stage are with class 3 malocclusion and retrusive maxilla or maxillary deficiency that may or may not be associated with mandibular prognathism. This is a case of a female patient who reported at the age of 9 years with unilateral cleft lip repair and palatal repair, but with a deficient palate repair, that is, was a fistula remained there. And now, in this patient, we had the unilateral cleft lip and palate, late mixed dentition, anterior crossbite, missing lateral incisors, residual fistula on the palate, and the midface deficiency. She had a reverse overjet due to maxillary retrognathism and residual palatal fistula due to surgical defect. Now, the objective at this stage for this patient is to correct or to coordinate between the transverse and anteroposterior relationship of maxillary and mandibular jaws and to get correct perfect overbite and overjet with the midline corrections and to get an ideal gingival display followed by rhinoplasty of this patient. For that purpose, there was a slight palatal expansion was carried out with slow maxillary expansion and followed by face mask therapy. She underwent face mask therapy for 4 months, and for that the extraoral elastics were given from the face bow with an angle of 30 degrees coming out of the lips, which will redirect, reposition and reshape the premaxilla for this child. The use of face mask causes a skeletal changes. It promotes a change in the facial architecture by modifying the shape and structure and direction of growth of the maxilla. Comprehensive orthodontic treatment was started in this patient where leveling and alignment was achieved and the area of missing lateral incisor was kept for a prosthesis later on. Extraoral photographs during the comprehensive orthodontic treatment where much of the alignment has been taken place and facial shape has started improving. This is a comprehensive orthodontic treatment where leveling and alignment has been achieved to quite an extent, but still there is a palatal fistula left in this patient, and positive overchecked level and alignment arches and much settled bite can be appreciated. This is all just a long playful journey which ends up in a very bright and happy smile of the patient. These are different values which shows that the A and B has improved from -2 to +1, and there has slightly increase in the direction of growth of the mandible, which has rotated downward and backward. Superimposition of sphelographs is the best way to judge the treatment results. That is, superimposing the pre-treatment and post-treatment records of the patients on the sphelograph shows that the maxilla has made a forward movement, mandibular has been rotated downward and backward. The red line shows the progress of the treatment in this patient. Treatment outcome is best evaluated with the sphelographs. And this is the upper arch with secondary palatal repair and the prosthesis for the lateral incisor in place. And this is the occlusion of the patient just before finishing with prosthesis and palatal repair, which was followed by rhinoplasty. Rhinoplasty for the nasoalveolar tip and the columellar lengthening was carried out in this patient. And this is a post-treatment smile of the patient, where she was very happy with her results and the occlusion and the shape of the nose. Pre-treatment and post-treatment results of the patients. And this is a complete treatment journey from a retrusive and retrognathic maxilla to a well settled picture of the teeth and the face. These images display drastic improvement from pre-treatment to the final stage, and we are successful in establishing a stable aesthetic functional results with the teamwork of orthodontist, maxillofacial surgeon, plastic surgeon, and the prosthodontist. The patient has achieved competent lips, nasal tip, elevation, and a beautiful smile. And these are the results of pre-treatment and post-treatment occlusion of the patient. Pre-treatment and post-treatment alveolar shape of the palate and the lower arch, which has become quite coordinated with the maxillomandibular occlusion. Nasal tip has been corrected, and the patient is a very confident and beautiful bride to be. You cannot imagine the happiness and the satisfaction when you treat a patient with a cleft lip and palate, and then the patient is a beautiful bride to be with a perfect smile. And I would suggest and I would request all of you that if you want to feel the real joy, the real satisfaction within you, just treat a cleft patient, I bet. Thank you very much for your kind listening.